Welcome back. In the chapter of preventive medicine and obstetrics, pediatrics, and geriatrics, in today's session we will be discussing about antenatal care. The definition of antenatal care: antenatal care is the care of the woman during pregnancy. Antenatal care. Antenatal is the care during pregnancy, the care which is provided by the healthcare professional. You can see the care which is provided by the healthcare professional to the pregnant women or the pregnant adults and girls in order to ensure the best health condition. Why do we give this care? To ensure best health condition. We want the best health condition of both the mother as well as the baby. Okay, this care is provided to ensure the best health condition of the mother and the baby. The care which is provided by the healthcare professional to the pregnant mother or the pregnant adults and girls is known as antenatal care. What are the objectives of this antenatal care? It is to promote, protect, and maintain the health of the mother during pregnancy. So, we know that during pregnancy, it is a very crucial period in the mother's life. So, we have to make sure that we protect the health and maintain the health of the mother during the pregnancy, and also detect the high risk cases and prevent the complications. So we know in high risk cases of pregnancy, we'll discuss in detail in the next slide. For now, certain examples: the gestational diabetes and hypertension, the smoking, alcohol, twin pregnancies, early pregnancies. These are high risk pregnancies. When the mother is suffering with gestational diabetes or gestational hypertension, in such cases, this is a high risk cases. So we have to detect this high risk cases, foresee any complications coming and prevent them. To remove the anxiety related to the delivery, and also to sensitize the mother for the need of family planning. The primary mothers, the first time who are pregnant, so the primary gravida, okay, she will have a lot of anxiety, the dread of fear regarding the delivery. So we have to remove the anxiety by providing the authentic information regarding the delivery, teach her, encourage encourage her for the normal deliveries, and also you have to remove that fear in her by explaining things to her. And also we have to sensitize the mother for the need of family planning. If it is the primary gravida, go for spacing methods. If she is multi gravida, okay, if she is a multi gravida, go for sterilization. So family planning methods have to be, the mother has to be sensitized about them. And also to reduce the maternal and infant mortality and morbidity. Mortality is the death, so we see mortality is death, morbidity are the diseases. We have to prevent the maternal, mother and the infants, babies, diseases and death. We have to prevent the mortalities and morbidities of the baby and the mother by foreseeing the complications and preventing them. Lastly, to attend the under 5 children who are accompanying the mother. So if the mother is a multi gravida, if there is a child who is accompanying her during the delivery, or who is accompanying her during the antenatal visits, we have to make sure that we attend this under 5 child as well. So these were the objectives of antenatal care. In addition to this, we also have to sensitize the mother for seeking the childcare information, and also regarding the nutrition of the baby, breastfeeding, and personal hygiene, environmental sanitation. All of these is included in antenatal care. We also have to teach the mother regarding the personal hygiene of her and the sanitation, the environment of the baby, how she has to take care, the nutrition, the weaning period, the breastfeeding, how she has to clean her nipple, and also the mouth of the baby to prevent the cracks and everything. She has to wipe it after every feed with the warm water. So all of these things we have to teach the mother during the antenatal care. So these were the objectives of antenatal care. Now moving on to the antenatal visits. So we have an ideal antenatal visit and a minimum antenatal visit. Ideal antenatal visits are 13 to 14 visits is an ideal visit. The minimum visits are 4. Okay, this is ideal, and minimum we have 4 visits. Okay, this is minimum. Starting with an ideal visit. So ideal visits, they are made from 1st to 7th month. Once a month 7 visits are made. So we know in per month, okay, per month there is 1 visit, so total 7 visits are made. In the 8th month onwards 2 visits are made. Okay, 2 visits twice a month, every fortnight or 15 days we make 2 visits in 8th month. In the 9th month onwards, 4 times a month. So every week she's needed to make a visit to the hospital or the CHC, PHC, sub center, wherever it is required. She has to make a visit every week in the 9th month onwards. So the total we see, the first 7 months 7 visits, 8th month 1 to 7 7 visits. In the 8th month she has to make 2 visits. In the 9th month onwards, every week, total 4 visits. It completes 13 weeks. So now, why have they given 14, 13 to 14? Sometimes the EDD extends beyond the 9 months. Beyond the 9 months, it exceeds. So the 14 visits are also possible. It can extend into the 10th month. So the 14 visits are also ideal. Moving on to the minimum visits. So the minimum visits are 4 visits. We know in rural areas people do not actually make the ideal 14 visits. Also the multigravidas, even in the urban areas, these multigravidas do not make 14 ideal visits to the PHC, CHC, subcenter, hospital or whatever. So we see that the minimum of 4 weeks is required. 4 visits are required. Sorry, minimum of 4 visits are required, which are which are somehow covering all the 3 trimesters of the pregnancy. Let us see when are these 4 visits done. The first visit is within the 12 weeks during registration. So within the 12 weeks the mother has to make, within the 12 weeks she has to make a visit, because the registration should be done within the 12 weeks. Okay, the second visit is from 14 to 26. Okay, 14 to 26 weeks. The third visit is between 28 weeks to 28 weeks to 34 weeks. Okay, fourth visit is from 36th week to term. Now, how do we remember this? So you see here 12, okay, 12 weeks, up to 12 weeks. Within the 12 weeks the first visit is made. We can remember this. Now add plus 2, okay, the second visit, 12 plus 2 14, until plus 2 here, plus 12. Okay, plus 2 and plus 12, 26 again, plus 2 is 28. So we got the third visit 28. 34, again 34 plus 2, we got the fourth visit 36. Here you have to add plus 12, here you have to add plus 6. So I will demonstrate again, you will understand better. So we see that first visit less than, within 12 weeks. Okay, next plus 2, 12 plus 2, it becomes 14. So the second visit number we got. Now again add 12 to this, we get 26. Again plus 2, 26 plus 2 28. So we got 28. Add half a number 6 here. So we got 34. 34 again, when we come here we add plus 2, 36. We got the fourth visit. I hope it's clear. Here I'll show you 12 weeks. 12 plus 2 is 14. 26 plus 2 is 28. 34 plus 2 is 36. 12, 14 to 26. To remember this, what we have to do? Plus 12 plus 6 you have to remember. And 26 plus 2 is 28. And 34 plus 2 is 36. So this was the number, how to memorize it. So this were all the visits. Registration of the pregnancy, we see that it should be done within the 12 weeks and it is the responsibility of ANM. It has to be done within the 12 weeks. Okay. Next, what are the services which are provided during the antenatal checkup? Now let us discuss in detail the services which are provided during the antenatal visits. The first one is the history taking. So we know that during the history taking, during the first visit, we have to make a detailed history of the women. We have to take a detailed history of that pregnant woman. Complete detailed history has to be taken. First, we have to confirm the pregnancy. In the first visit only, we have to first do the pregnancy test and we have to confirm the pregnancy. Next, followed by, we have to identify whether there were complications during her previous pregnancy, so that if there is any complication, we can get a confinement that there may be a bearing even on the present one. So we will get an idea it might have affected even the present pregnancy. So we always have to make sure that we identify if whether any complications were present during her previous pregnancy. Next, we have to record the date of the first day of the last menstrual period. Why do we record the date of the first day of last menstrual period? So that we can calculate the expected delivery date of the mother. Okay, so the pregnancy complications, now EDD. Why do we record the first day of the LMP? First day of the last menstrual period, so that we can calculate the EDD. How do we calculate the EDD? First day of last menstrual period plus 9 months. So we have to add 9 months plus 7 days. 9 months and 7 days. We get the what do we get? EDD. Okay. Let us again see the formula of EDD. EDD is calculated by taking the first day of last menstrual period plus 9 months plus 7 days. Okay, 9 months plus 7 days. Okay, this is how the EDD is calculated. So in the history taking, we saw the complications and the date of the first last menstrual period, so that we can calculate the EDD. And how we calculated the EDD, we have seen. Also, we have to record the history of any current systemic illness. We have to record if there is systemic illnesses like hypertension, diabetes, if the mother has epilepsy, asthma, reproductive tract infection, HIV, AIDS, STD, TB, renal diseases, any of the systemic illness if she is having, we have to find out. Also, the family history of hypertension, diabetes, thalassemia, or twin pregnancy has to be inquired. Family history of twins and also the congenital malformations have to be inquired. Okay, the family history of the systemic illnesses like HT, diabetes, thalassemia, and twin pregnancies or malformations in the family. Lastly, the history of drug allergies and habit forming drugs have to be inquired. So this was regarding the history taking. Also, we have to record the symptoms which are slightly indicating towards the complication, like if the mother is having fever, or there is persistent vomiting, abnormal vaginal discharges or bleeding, if she is becoming easily fatigued or breathlessness is seen even on mild exertion, if there is certain swelling in the body. So when we see the risk signs of the danger signs of the pregnancy, then we will discuss in detail. For now, even during the history, if there are certain symptoms like the fever or palpitations, if she's having headache, blurring of vision, if she's passing urine, burning micturition, if the fetal movements are absent, these are all the danger signs. So we also have to inquire about all of these, and if they are present, we have to record it in the history as well. So this is regarding the history taking. So let us summarize history taking again, guys. Complications during previous pregnancy has to be inquired. In the second thing, we have to ask the last menstrual period and calculate the EDD. You can write how do we calculate the EDD in the next point. Lastly, systemic illnesses and family history, if there are any illnesses. Systemic illness, again write family history, HT, diabetes mellitus. Systemic illness, again if the mother has HT, diabetes mellitus, asthma and so on. History of drug allergy. Fifth one, drug allergy and habit forming drugs. So this was about the history taking. Moving on to the physical examination. In the physical examination, let us begin with so what all do we have? We have pallor, and edema, blood pressure, weight gain, and so on. Let us begin with pallor. Pallor indicates anemia. So we know that the presence of the pallor in the mother indicates that she is anemic. The woman should be examined for the pallor. At each visit, you always have to examine the mother for the pallor. How do we examine? How do we, find out if the mother is having pallor? We have to examine the woman's conjunctiva, her nails, ask her to stretch out the tongue, her oral mucosa, and also check her palms. Pallor should be correlated with the hemoglobin estimation. So we know whenever the HB is low, the pallor is there. So we have to correlate with the HB values. So we see that how do we indicate pallor? How do we find out if pallor is there? Conjunctiva, nails and palms, and in the mouth we see tongue as well as the oral mucosa. This was about the conjunctiva, nails. So how can you remember? Conjunctiva, tongue and mouth, oral mucosa, and palms and nails are examined. So this was about pallor. Moving on to edema. Next we see in the mother. So we saw pallor in her. Next we are looking for edema. Edema, guys, edema, a very important sign, okay? Edema is also known as swelling. In the layman language, she will tell you, doctor, I have swelling. Or you can notice edema or swelling, which will appear especially in the evenings and it disappears in the morning. After a full night's sleep, it will be disappear. This could be a normal manifestation of pregnancy. So as doctors, we also have to be aware of what is normal during pregnancy and what is abnormal. So we know that the edema which is occurring in the evenings and which is occurring in the evenings and it will disappear in the morning after she's having a full night's sleep, a good sound sleep. When she wakes up in the morning, the edema goes away. Then it is a common manifestation of the pregnancy. But if the edema is found on the face, on her hands, abdominal wall, or if it is found in the vulva, it is abnormal. So we see that edema, if it is found in the edema, if found on the face, so we see edema on the face, hands, abdominal wall, and vulva, it is considered to be abnormal. Face, hands, abdomen, vulva, it is considered to be abnormal. Okay, always remember it is abnormal when it is on the face, hands, abdomen, and vulva. Moving on, we see that edema, it is a good it is a sign because if edema can be suspected if the woman will complain of abnormal tightening of rings on her fingers. We know that how will she complain? She tells that the rings what she's wearing or the toe rings, in Indian culture they wear toe rings as well. So the toe rings or her finger rings, they have become very tight. She refers them to be tight, and if there is edema, we know that there is an association with high blood pressure. When there is high BP or proteinuria, which can result in preeclampsia. Also, there could be heart diseases in the mother, or anemia could be there. So we have to see that it does not affect the delivery or the baby. So we have to make sure that we have to treat the preeclampsia. What is preeclampsia, guys? Blood pressure plus proteinuria. We know there are two things. We have eclampsia and preeclampsia. For now, what is preeclampsia? High blood pressure plus proteinuria. There is a loss of protein in the urine. Proteinuria is preeclampsia. So the edema will be present in cases of preeclampsia. When it is associated with convulsions, it is eclampsia. When high BP, proteinuria plus convulsions are found, it is eclampsia. For now, when there is only high BP and proteinuria, she is directing towards preeclampsia. Next, blood pressure. We have to measure the woman's blood pressure at every visit. So the pallor has to be checked at every visit, and we also have to check the blood pressure in every visit. High BP will signify the pregnancy induced hypertension. So this is very important to rule out the hypertensive disorders of pregnancy. So we have to check the BP in every visit. Hypertension will be diagnosed with 2 consecutive readings. Also remember guys, hypertension. Now we are going to discuss about hypertension, blood pressure. Okay, how are we going to do it? The blood pressure, it will be diagnosed in 2 consecutive readings which are taken 4 hours apart. Okay, we know that we take 2 readings 4 hours apart. Okay, 4 hours apart, once here, and after 4 hours again she will be checked. So if the systolic blood pressure will be 140, so we see that if the systolic blood pressure is 140 mmHg and the diastolic blood pressure is 90 mmHg or more, then hypertension is diagnosed. So how do we diagnose hypertension? Systolic and diastolic. 140 by 90. When it comes, we consider it as hypertension. Moving on, high blood pressure during pregnancy, it signifies that there is pregnancy induced hypertension or it is a chronic hypertension. Also, if the woman is having high blood pressure, we have to check her urine as well, so that if there is a presence of albumin, then it shows that the mother is suggesting towards preeclampsia. We have to treat her immediately. So we have to see that if the mother has high blood pressure and also her protein shows proteinuria, then she's suggestive of having preeclampsia. Moving on to weight gain. So weight gain, there is an ideal weight gain. A pregnant woman's weight should also be checked during every visit. So the weight has to be taken during first visit, and the registration should be treated as a baseline visit, so that we can have a baseline for the visit. So we have to make sure the weight has to be checked in the first visit. So we see that if the first visit the mother was 60 kg, we can consider it as a baseline and have a track of each trimester how much weight is being gained by the mother. So ideally, after the first trimester, a pregnant woman will gain around 2 kgs every month. So we see that 12 kgs ideally they gain during pregnancy. So we also got an MCQ here. Poor or underprivileged Indian women will gain 6.5 kg. See, the underlined part are the MCQs. So pre-PG exam MCQs. We are also synchronous with this, we'll be studying about the MCQs, and simultaneously we will finish off the NEET pre-PG preparation as well. So we see that 6.5 kg if there is a gain in the underprivileged Indian women, okay, who belong to the lower social status, who cannot afford good food and nutrition. The ideal gain has to be 12 kgs, but the mother is only gaining 6.5 kgs if there is underprivileged or poor women. In the first, now let us see 12 kgs. How have they divided the 12 kgs into? In the first trimester, 2 kgs. Okay. In the second trimester, 5 kgs. In the third trimester, again 5 kg. So we see that the mother is likely to gain 2 kgs in the first trimester, 5 kgs in second, and other 5 kgs in the third trimester. The low birth weight is suggestive in case if there is a low weight gain. If there is a low weight gain, if 12 kgs is not there, if the mother is not gaining weight as per the ideal weight gain during each trimester, it is suggestive of intrauterine growth retardation, or we have to be prepared for the low birth weight baby. If there is excessive weight gain, if there is excessive weight gain of more than 3 kgs in a month, this should raise a suspicion of preeclampsia, twin pregnancy, multiple pregnancies, or diabetes. So we see that if there is preeclampsia, there will be edema. In cases of preeclampsia, there will be edema and the weight gain will be more. And in cases of twin pregnancies, weight gain will be more. Multiple pregnancies, more. Diabetes, big baby. We know we have studied in obstetrics. In diabetes, we get big baby. Okay, big baby in cases of diabetes. And low birth weight baby when there is smoking and alcohol consumption by the mother and various other factors which we'll discuss in the next slides. Then it is intrauterine growth retardation and low birth weight when the mother is not gaining weight. Moving on, we have the third point, that is abdominal examination. Examine the abdomen of the mother to monitor the progress of the pregnancy, also the fetal growth. So why do we examine the abdomen of the mother? So that we can monitor the pregnancy and also the fetal growth. So we see that the abdominal examination, we measure the fundal height. By the measurement of the fundal height, we can examine the enlargement of the uterus and also the height of the uterine fundus. We can get to know the weeks of the gestation. In 12 weeks, it will be the fundal height will be at pubic symphysis. So we see that the height will be at pubic symphysis in 12 weeks. So in 12 weeks it will be at pubic symphysis. In 24 weeks it will be at the umbilicus. Fundal height will be at the umbilicus. In 36 weeks it will be at the symphysis, at xiphisternum. At xiphisternum. Again guys, let us revise it. 36 xiphisternum, 24 at umbilicus, and 12 weeks it is symphysis pubis. Okay, now moving on to, so we see that in 12 weeks the uterine fundus will be palpable in the abdomen. In 28 weeks the fundus will be flat at the lower border of the umbilicus. We can see a flat thing at the lower border of the umbilicus. In 36 weeks you can feel the fundus at the level of the xiphisternum. So the duration of the pregnancies can be expressed by the completed weeks here. Okay, now moving on to the fetal heart sounds. The fetal heart sound can be heard after 6th month. So we see after the 6th month we can hear the fetal heart sounds. The rate will vary between 120 to 140 per minute. They're usually heard by 6th week. So we know that the fetal heart sound will be heard by 6th week. Through the USG, we get to know the fetal heart sound will be 120 to 140. I'm sorry, I said month wrong. It is not month, it is 6th week onwards. I'm extremely sorry. We have the fetal heart sound heard at the 6th week. Okay. The 6th week onwards, the fetal heart sound will be heard. That will be 120 to 140 beats per minute. Fetal movements can be felt by the examiner after the 18th week onwards. By gently palpating the abdomen, you can start feeling the fetal movements by 18th week. Okay, felt after the 18 weeks, you can feel the fetal movements. Fetal lie and presentation will be relevant after 32 weeks. So it is very important to know the fetal lie and presentation. So sometimes there will be breech presentation. If there is a head, then it is good. Okay, if there are buttocks or there are feet, hands, shoulders, so the breech presentations will be there. Sometimes the transverse lie, the baby might be lying transversely here, so we cannot it was not good for the delivery. Easy delivery won't be there. There will be complications during delivery. So, the fetal lie and the presentation can be relevant after 32 weeks. The inspection of the abnormal scars. We have to inspect the abnormal scars or any other relevant abdominal findings to find out if she has any operations done prior and she has forgotten about them. Long years ago, she had got an operation done. So the abdominal scar, the surgical scar marks will give us an idea about the any examinations or sorry, undergone any surgeries. So this was about the fundal height and fetal heart sounds, fetal movements, fetal lie and presentation, and inspection of the inspection of the abnormal scars. Moving on to the assessment of the gestational age. The measurement of the gestational age has changed over the time. So we see that now there is introduction of ultrasound, and from the date of the LMP, last date of the LMP, we can calculate the gestational age of the baby. Moving on to the counseling. So now we know that the most, before going to the counseling, let us see the gestational age. The gold standard method for the assessment of this gestational age is USG. If they ask you what is the gold standard for measuring the gestational age of the baby, so you can say USG is the gold standard method for measuring the for assessment of the gestational age. Also, the gestational age can be based on the date of the last menstrual period, which is the widespread used method. In many settings, we use this method where the last day of the LMP is used. The first day of the last menstrual period will be considered, and the gestational age is calculated accordingly. Okay. So this was about the abdominal examination. So guys, let us summarize. In abdominal examination, we have to see the fundal height. First we see the height. Then the heart sounds. Fundal height, heart sounds. The movements. Fundal height, heart sounds. In the heart sounds, in the height we know very well. 12 weeks xiphisternum, 24 umbilicus, 36 symphysis pubis 12 weeks, xiphisternum 36 weeks, 24 umbilicus, and then fetal heart sounds, we 6th week onwards we hear the fetal heart sound 120 to 140. Then in the movements we know it can be assessed by 18th week onwards. Then the fourth one is the lie and the presentation of the baby, so that is by 32 week onwards, and inspection of the abnormal scars. This is very easy now. Let us revise again. Fetal height, okay, fetal height, heart sounds, movements by 18 weeks, and we have fetal lie and presentation by 32 weeks, and the abnormal scars. The gestational age, ultrasound is the gold standard method. We also use first day of the last menstrual period. It is a widespread used method. Then the counseling. Now we are moving on to the next part, that is counseling. The information of the Janani Suraksha Yojana is given, and the mother with 2 or more children is motivated for sterilization. So we know that in counseling we give awareness about the Janani Suraksha Yojana to the mother, and also motivate the multi-gravida or the mother who has completed her family size to undergo sterilization. Okay. This is regarding the counseling. Moving on to the laboratory investigations. These following laboratory investigations have to be carried out. So at the subcenters, at the PHCs, CHCs, and FRU. So we see that at the subcenters, what are the investigations carried out? We do the pregnancy test, that is Nischay kit. We have studied about this Nischay kit, okay, in the previous demography and family planning. Nischay and Nischay, there is a difference, okay. This is for TB. Nikshay is for TB, wherein 500 rupees have been given to the TB patients for their food, and as a support we give 500 rupees per month for the TB patients. That is Nikshay. Here Nischay, okay, Nischay, Chay, okay. Nischay kit is a pregnancy kit by the government. So it's Nischay and not Nikshay. Don't forget it. Chay, okay. Chaya, we know under the brand name Chaya all the contraceptive methods. So Nischay is the pregnancy kit. So Share is for TB, and online patient management system for TB is done. For the next year, we have the online management system. Also, the laboratory investigations we were studying. So in the sub centers, what do we have to do? We have to check the mother's hemoglobin. Urine test has to be done for albumin and sugar, so that if there is a protein loss or there is any UTI, we can make out. And rapid malaria test has to be carried out. Now moving on to at the PHC or the CHCs, what we have to do. In the PHC and CHC, the blood grouping including the RH factor have to be done. So we know if there is RH positive and RH negative, if there is a difference between the RH factor of the mother and the fetus, it can end up into erythroblastophetalysis. So we know that to prevent such complication, the RH factor of the mother has to be found out, and the blood grouping has to be done, so that in any emergencies, if the blood transfusion is required, prior the arrangements can be done. So the blood grouping and the RH factor have to be found out. VDRL test has to be done. HIV testing, blood sugar testing, and HBsAg for hepatitis B infection. We have to be do. We have to be. It has to be done. Okay. Rapid malaria test, if it is unavailable at the PHC, you can ask them to get it done at the sub center. So these are very essential in essential laboratory investigations. Now let us summarize them. At the sub center, we have pregnancy test, that is Nischay test. Then hemoglobin, pregnancy test, hemoglobin, urine test, and rapid malaria test. So these three you can remember: pregnancy, blood test, urine test, and last is malaria, rapid malaria test. This was about the sub center. Very simple. Now moving on to PHC or CHC. What do we have at PHC and CHC? We have here, we only check the HB. Here we will do the blood group testing and RH factor, VDRL, HIV, and blood sugar test, and HBsAg test for hepatitis. So again, memorize this: blood grouping, VDRL, HIV, blood sugar testing, HBsAg. So these are the tests which are carried out in the centers. Moving on to the risk approach in ANC. Risk approach. The central purpose of antenatal care. What is the central purpose or the objective, what we studied in the second slide? It was that we have to identify the high risk cases as early as possible. From the large group of antenatal mothers, we have to identify who are the high risk patients, so that we can arrange a skilled care for them. We can protect and promote the health of the mother and the baby. So these cases will comprise the following. What are the high risk cases? We see that early primey or a short stratured primey, early primey or a short stratured. So we see that if the primey, if she is very early primey, elderly, okay, sorry, we also have early as well as elderly primey. Elderly primeys are those who are 30 years and above. Elderly primeys are 30 years and above, or a short stratured primey. Elderly grand multipara, multiple pregnancies, okay, grand multipara, and also she is elderly, 30 plus, 35 plus. History of 3 or more spontaneous consecutive abortions. So we see that spontaneously, consecutively, she has 3 abortions, and this is the 4th. So we see that she is at a high risk of having an abortion. So the history of 3 or more spontaneous consecutive abortions. History of previous stillbirth or intrauterine death. If she has a stillbirth is the baby which was born was dead, okay, dead baby being born, or intrauterine death, in the uterus itself the baby died, intrauterine, or the baby was born but it was born dead, okay. So the history of previous stillbirth or intrauterine death. History of previous C-section. So we see that if the mother has undergone C-section and it's not a full-term normal delivery, instead it is a C-section, cesarean section operation. Then if there is a previous cesarean section, then she is at she falls under the risk approach. And then malpresentation, breech presentation, or a transverse lie. We have studied all of this. So ideally, if the head is found like facing this in the cervix, then it is ideal. Okay. If there is shoulder, or if there is buttocks, or the leg, or the hand coming out, so all of this, the malpresentations, breech presentations. And we also have transverse lie. If the lie is transverse, if the baby is lying transversely here, the head is not facing, neither the buttocks are facing, the baby is lying transversely in the abdomen, then it is a high risk case. Malpresentation, breech and transverse lie. Twins. So we see twin pregnancies are the risk pregnancies. Anemia in the mother. Preeclampsia and eclampsia. So we have studied about preeclampsia. What is preeclampsia? Blood pressure, that is hypertension plus proteinuria is preeclampsia. When there is hypertension plus proteinuria plus epilepsy, that is convulsions. If the mother throws convulsions, then it is eclampsia. Pregnancy along with cardiovascular diseases, diabetes, TB, HIV. So when we were taking the history of the mother, we studied that we have to record the symptoms which will indicate the complications. If the mother is suffering with the systemic illnesses like cardiovascular diseases, diabetes, TB, HIV, STD, reproductive tract infections, asthma, renal diseases, malaria, etc., we have to consider her under the high risk, and skilled care has to be taken for her. Okay, so this were the risk approach cases in ANC. High risk pregnancy, what are those? Elderly preemie. Okay, I'm sorry, elderly preemie, 30 to 35 above. Elderly preemie, short statured preemie, elderly grand multipara, consecutive abortions, spontaneously consecutive abortions, 3 or more, stillbirth, previous stillbirth or intrauterine death, previous C-section, malpresentations, breech and transverse lie, twin, anemia, preeclampsia, eclampsia, HIV, TB, cardiovascular diseases, diabetes, etc. if the mother is suffering with all these cases. So this was about the risk approach in ANC. Moving on to the maintenance of records. So we see that we have this charts which will be given in our Viva Voice practical examinations. So what is this chart here? This chart is the MCP card. Okay, that is the mother and child protection card, MCP card. When they give this card for identification, what will you write? MCP card. What is this? MCP card, mother and child protection card. Okay, so the mother and child protection card should be duly completed for every woman who is registered. We have to provide this card for the mother. It will contain the registration number. So we have each individual number which is given for the mothers who are attending the PHC CHCs. We have to give her this card, MCP card, and the card will contain the registration number, identifying data. So the data, the name of the mother, spouse, previous baby's name, or whatever, the family member, the guardian. It will contain the identifying data, previous health history, and the main health events if she is undergone. If there is a previous spontaneous abortion, or there was previous stillbirth, intrauterine death, all such things have to be noted there. And then the case record should be then handed over to the women. We have to make a enter all the data of whatever is asked, fill the columns. Then you have to hand over that card to the women. You have to instruct the woman to bring this record during all her subsequent checkups or the visits. She have to carry this card along with her. Also during the delivery, she has to bring this MCP card with her. And this card was developed by the Ministry of Health and Family Welfare. So they introduced this card to bring uniformity in record keeping. Also, this will give the details of the previous ANCs, PNCs, and routine and emergency cares to the service provider. She don't have to keep asking multiple questions. Just take this card, have a look. You will get to know entire details regarding the number of visits, the entire history of the mother and the baby who is being born will be written in that. It will be recorded. The information which is contained in the card will be recorded even by the antenatal register. We have to make the information, again we have to make the information to be recorded in this register. You have to transfer all the data from this card in the antenatal register and maintain the register. So this was all about the MCP card. Moving on to prenatal advice. A major component of the antenatal care is the prenatal advice or antenatal advice. Okay, the mother will be very receptive. She will be more receptive to advice which is concerning herself or her baby. At this time, she'll be very receptive. Okay, so the points should cover the specific problems of the pregnancy and her childbirth. We have to make sure that we give the right information to her. The light household work is advised. You have to advise the mother to have a good normal delivery. She has to carry on the light household work and avoid the constipation. If the mother has a habit of smoking or alcohol, she has to stop it immediately, because the smoking can result in low birth weight baby, and if the mother consumes alcohol, it can lead to the developmental delays, congenital abnormalities in the baby. Okay, developmental, her milestones of the baby will be delayed. Okay, so she has to tell the mother regarding the constipation. To avoid the constipation, she has to take a regular intake of green leafy vegetables, fruits. Extra fluids have to be taken. Also, purgatives like castor oil should be avoided. To relieve the constipation, she should not take castor oil, because certain things can result in spontaneous abortions. Purgatives, castor oil, all such things have to be avoided. Rather than this, she can opt for green leafy vegetables, fruits, and fluids. Intake of good amount of water. Also, you have to tell her about the rest and the sleep. 8 hours of sleep or at least 2 hours rest after the midday meal should be advised. Total 10 hours sleep, 8 hours during night and 2 hours after the midday meal. After lunch, she has to sleep or rest for 2 hours. Also, regarding the personal hygiene, we know antenatal care, we also deal regarding the personal hygiene, personal cleanliness. A mother is encouraged to take bath every day. You have to tell her to wear clean clothes. This should be explained. People in urban areas too busy, mothers, and in rural areas unaware of all these hygienic practices. We have to, educate the mother regarding her personal hygiene. Her hair should be kept clean. She should wear clean clothes, take bath every day, etc. Also, she should avoid the brisk physical labor. Excess physical labor should be avoided, because it can affect the fetus. Manual physical labor, especially during the late pregnancies, she should avoid it, because it can adversely affect the fetus. Smoking, we know it should cut down, so that because it will prevent the low birth weight baby. If she does not cut down smoking, then she has to be prepared to get a low birth weight baby. So, moving on. Heavy drinking, we have fetal syndrome, FAS, where there is intrauterine growth retardation, developmental delays in the baby. So if the mother is consuming lots of alcohol, in the recent studies we see that it can cause spontaneous abortions as well. And regarding the sexual intercourse, this has to be restricted during the last trimester. It is restricted, especially during the last trimester. The sexual intercourse has to be restricted. Moving on to the drugs. So, the use of drugs are not absolutely essential, but they have to be, that are not absolutely essential should be discouraged. We have to discourage the pregnant mother to take any drugs. We have to discourage her. The certain drugs taken by the mother during pregnancies can affect the fetus adversely. So they can cause fetal malformations. So we have to make sure that the mother is completely discouraged to intake of any sort of drugs. The streptomycin can cause the eighth nerve damage resulting in deafness, and the intake of tetracycline will affect the growth of the bones and the formations of teeth in the mother. Also, we have certain corticosteroids which will impair the fetal growth, sex hormones. They can produce virilism, and we know that corticosteroids they can produce virilism in the baby. So, all such things that iodine containing drugs, if you take, they can cause congenital goiter in the fetus. So, we have to make sure that we discourage the mother to take any sort of drug preparations. Next, we have radiation. Exposure to radiation is a danger to the developing fetus. So, we see that the most common source of radiation is this abdominal X-ray radiation during pregnancy. So, we had this case cohort studies. They showed that the mortality rates, the death rates from leukemia and some neoplasms, microcephaly, all this was significantly greater in the children who were exposed to this intrauterine, X-ray exposure. So, in addition to this, we also have congenital malformation like microcephaly and cancers like leukemia, which are occurring because of this exposure to the radiations. Warning signs during pregnancy. So, the mother should be given a clear cut instruction. Antenatal care. We have to give a clear cut instruction to the mother that she has to report immediately in cases of these warning signs. When there is swelling of the feet, fits, headache, blurring of the vision, bleeding or discharge per vagina, or any unusual symptoms she observes, she has to visit the PHC, CHC, or the hospital immediately. Okay, the warning signs: swelling of the feet. Remember, guys, swelling of the feet, fits, blurring of vision, bleeding or discharge per vagina. You can see here visual disturbances, burning micturition, if there is decreased movements of the baby, fever, abnormal vaginal discharges, palpitations, breathlessness, severe abdominal pain, severe headache, blurring of vision, excessive vomiting, vaginal bleeding, if there is swelling of the feet. So, these were the warning signs. Moving on to the specific health protection. So, the specific health protection includes the iron and folic acid supplementations for anemia. So, according to NFHS 4, 50% of the pregnant women in India are anemic. Sadly, 50% of the pregnant women in India are anemic. So, the major causative factor is the iron and folic acid deficiency. It is well known that anemia is associated with the incidence of premature births. We know that premature births, which we are seeing a lot often today, or the postpartum hemorrhages, puerperal sepsis, all of this is having a direct correlation with anemia. So, the government of India now has initiated a program in which the 100 mg of elemental iron, or 100 to 60 mg of elemental iron, and 500 mcg of the folic acid are being distributed daily for 100 days to the pregnant women. Throughout the antenatal clinics, PHCs, CHCs, we have this, sub centers, we have the supplementation of iron and folic acid tablets. We start the supplementation from the 4th month of the pregnancy. 100 days we give this. Okay, we start from the 4th month of the pregnancy. We continue it. Along with this, we continue the supplementation throughout her pregnancy. Minimum 180 days. Minimum 180 days we have to give the supplementation. Along with this 180 days, they have to be continued plus 180 days of the postpartum period. So we begin from the 4th month. And continue completely throughout her pregnancy Postpartum period 180 days. Again, in her postpartum period, we have to give the iron and folic acid tablets, which are containing 60 to 100 mg of elemental iron and 500 mcg of folic acids. They are the red color tablets. To be continued for 180 days of postpartum period, iron is never given together with calcium. Very important thing. The doctors, physicians, we have to know that the iron should never be given together with the calcium. Moving on to the other nutritional deficiencies, the mother has to be protected against the other nutritional deficiencies which can occur. Particularly, we have this protein, vitamin, mineral deficiencies like vitamin A deficiency, iodine deficiencies. So now we have this fresh milk which is provided to the mother free of cost to the expectant mothers. Where this is not possible, the skimmed milk can also be given. Also, we give this capsules of vitamin A and D which is supplied free of cost. Additional calorie requirement, this is very important. This was about the nutritional deficiencies. We give vitamin A tablets, vitamin D tablets, fresh milk to the mother. This was all about the nutritional deficiencies, how it is dealt with. Additional calorie requirement in the pregnancy is 350 kilocalories per day. No extra calories are required during the first trimester. This is an MCQ which has appeared in the previous question papers. Additional calorie required during pregnancy is 350 kilocalories. Immunization with the TD. So we see that we are speaking about the immunization. 2 doses of TD 1 month or 4 weeks apart has to be given as soon as possible. We see that tetanus and diphtheria immunization, the vaccine will be given 1 month or 4 weeks apart. If it is delayed anytime in the pregnancy, irrespective of the time of the pregnancy, the TD immunization has to be done. It provides the protection for at least 3 years. Whereas in cases of the multigravidas who are completely immunized in the last 3 years, one booster dose will suffice. In cases of multigravida who are immunized in the last 3 years, one booster dose will suffice. So we see that when such a booster dose has been given, whatever the necessary things which are required, they will cover for the subsequent pregnancies during the next 5 years. So one booster dose has to be given. Okay, who has only for a woman who has been immunized earlier. Only for the women who are immunized earlier, the booster dose will be sufficient. Okay, because it gives the it provides the necessary cover for the subsequent pregnancies for the next 5 years. So it is advised not to inject this tetanus toxide at every subsequent pregnancy, because hyperimmunization and side effects can also occur. If in every pregnancy, if your complete immunization schedule is followed, then the hyperimmunization and the side effects regarding this can occur. So the tetanus and tetanus toxide has to be given only a booster dose for the women who are immunized previously. Next, RH status. We know RH anti-D immunoglobulin is given at the 28 weeks of gestation, so that if there is any the possibility of erythroblastophytalysis, that can be prevented. So we know that fetal red cells will enter the maternal circulation in number of circumstances, especially during the cesarean section. The fetus blood can enter the mother's blood can enter the fetus blood. Mixing up can happen. Also during the therapeutic abortion, what we do, the MTPs, or during the labor, and apparently spontaneously even in the late pregnancies it can occur. So if the mother is RH negative and the child is RH positive, then immune responses in the mother will develop. So the antibodies regarding opposite to that RH will develop, resulting in the fetal hemolysis, and the immunization against it is very important to prevent the erythroblastophytalysis. So the RH status and the RH anti-D immunoglobulin in 28 weeks of gestation. Prenatal genetic screening. So they are talking about the prenatal genetic screening. Screening for the hemoglobinopathies, Down syndrome, neural tube defects has to be done, so that if there is any chromosomal abnormalities which can result in the birth defects can be prevented. The screening for the direct evidence of the congenital anomalies, and we have to screen for hemoglobinopathies, Down syndrome, and neural tube defects. Okay. Women, also the women who are aged 35 years and above, they have a higher risk of having this genetic abnormalities, so we have to do the screening in them. So we see that anti-D immunoglobulin, and this is tetanus and diphtheria toxoid, TD, and these are the iron tablets. So this was the specific health protection. Also, in the specific health protection, you can also mention about hepatitis B infection. For hepatitis B infection, we have to prevent this by giving the vaccine, and also HIV infection can also pass. So we have to do the screening. Okay, it can be used as a substitute for the primary prevention, so that we can prevent, the primary prevention can be done, so that the risk of transmission can be prevented from the mother to the baby. So the screening has to be done for the HIV infection, and also hepatitis B infection, German measles as well, the maternal viremia which is associated with rubella infections during pregnancies. They can, this maternal viremia which is associated with rubella, the German measles, so this can result in the infections of the placenta, infection of the fetus. Then this infection can derange the organ development in the baby, resulting in the anomalies in the newborn. So we have to also detect this German measles and give the required immunization. So this was about the syphilis as well. So what are the additional things we saw? We saw syphilis, German measles, HIV, and hepatitis. Okay, additional, you can write this as well. So this was all about the antenatal care. I hope everything is clear. If you have any doubts, put it in the comment section, and if you like my video, hit the like button and subscribe.